Hi, friends. Welcome to Heartforward, Conversations from the Heart. You have heard me say in my commentary over the past 3 seasons that it makes no sense to try to fix our mental health system around the edges. It requires bold system change. We have built this system in America on a medical model, tied to clinical interventions that sublimate the very things we have seen work well in other contexts. How about we commit to a whole-life, human-centered system instead of a clinical model? Most of my interviews celebrate this alternative. I would call your attention to Dr. Mary Watkins in Season 1, talking about mutual accompaniment. Or how about Dr. Ashwin Vasan, also in Season 1, talking about the clubhouse model. I felt it was important to return to a story that needs to be told again, about the state-funded pilot from the early 1990s at the Village in Long Beach. It's a case study that resonates today, and the findings revealed 3 key things. 1, how we pay for mental health services really matters. Payment reform makes a huge difference. Ditch the customary Medicaid reimbursement paradigm. We have to pay for what people need to recover, not for what institutions need to be reimbursed. 2, we have to meet people where they are at, and at the moment they need to be met. We have to be willing to go to them and come alongside them in relationship. And 3, we have to be willing to offer whatever it takes to help people on their recovery path. And maybe that leads to a 4th revelation. We have to believe that people can recover from their mental illness. A mental health diagnosis does not mean that your life and your dreams are over. As you will hear from this conversation with Dr. Dave Pilon and Dr. Mark Ragins, both who were intimately involved with conceptualizing and implementing this pilot, this is less expensive than what we do today and far more effective. Please note, Dave will speak first. Good morning. I am so pleased to have here in person Dr. Dave Pilon and Dr. Mark Ragins. We are here in Glassell Park in the studio. No more of the Zoom podcast interviews. This is just so much more fun. Thank you for taking the trip up here to be with me today.
It's great to be here. Thanks for having us.
A pleasure, Carrie.
Awesome. So, gentlemen, today we're going to tell a story. Tell a story about the impactful pilot that both of you were involved with at the Village Mental Health America in the early 90s. And I really want to make this kind of a oral case study that will stimulate people to think about the precursor, the reasons why this study, the pilot, was implemented, and how the lessons learned are completely relevant today, if not more so. So we're gonna walk through that trajectory. And what I'd like to do in terms of introducing you, because I will put your bios in the episode notes, and everything we talk about will be referenced in the episode notes, but maybe to introduce yourselves in the context of how you both came to get to know each other, how you both arrived at the Village. So maybe you could share from each of your perspectives that story.
So what I'd have to start with was my first experience in psychosocial rehabilitation, actually, which goes back to 1982, long before the Village was created. And I was a newly minted PhD living in Cambridge, Massachusetts, looking for a job. And I saw an advertisement for an outreach worker in Lowell, Massachusetts at the Mental Health Association of Greater Lowell at the time. And it seemed like a real interesting job to me. So I went up and I interviewed for the position. And the program was located in a old Victorian style house on the outskirts of Lowell. And I was greeted at the door by a young man, probably about 20 years old. He said, "My name is Scott. I'm here to show you around the program before I take you to meet the program director, Connie." He showed me around the program. And my own experience with mental health up to that point had been primarily psychiatric hospitals and very clinically oriented situations. And this looked completely different. All the people were engaged in clerical work or janitorial work. And I wasn't familiar with the idea of a clubhouse at that time. But Scott showed me around to all of these places, and I was just taken with it. And he dropped me off then at the director's office. Her name was Connie. And Connie sat me down and said, well, what do you think of the place? What do you think about working here? And I said, this place is amazing. So if all the staff are like Scott, I would love to work at this place. And she hesitated for a moment and she said, well, Scott's not a staff person here. He's a member. And you have to remember, this was actually 1981. And so I thought, I had no clue what she was talking about at that moment. And so I said, what do you mean by member? I said, well, you might refer to them as a patient kind of thing. And I cannot tell you how mind-blowing that was for me at that moment. It was like, this was just a totally new experience, because it occurred to me that Scott understood the people that were, being treated or provided services there a lot more than I understood them at the time.
And you had an advanced degree.
Exactly. It's like, this was just, as I say, mind-blowing for me. So that was the start of my introduction to the world of people with severe and persistent mental illness. And I can't tell you how great that was the experience that I had, because up until that time, it seemed to me that they were not capable of anything. And
so that launched you on a trajectory. It could have been completely different if you had ended up in a clinical assignment somewhere.
Exactly. It just made me begin to understand that people were capable, even in the throes of a severe mental illness, were capable of so much more. I didn't have the terminology for it at that time. Nobody was talking about recovery at that time, but it put me on a path to be able to understand that when I ran into people like Mark later on, who could sort of help me to sort of like form more cogent ideas around that.
So how did you run into Dave then, Mark?
Actually, let me make one comment first on David's in the lessons learned piles from the very beginning. How many psychologists and psychiatrists have training experiences where they spend a month in a clubhouse seeing people in this setting, or are they all in hospital and clinic settings being trained by other medical model people? That'd be lesson one.
Wow. Yeah.
So I was a little weird from the beginning. I became a doctor intending to be a psychiatrist and did all my elective time in psychiatry. And I was very interested in people with psychosis, the most affected people. And so I came to USC, to Big County. I was from Los Angeles in the first place because there was tons and tons of people with serious mental illnesses at USC there to learn from people. And I even did elective time there at the day treatment at Hollywood Mental Health, at Skid Row, at LAMP, at USC Alternatives Program, or residential places, looking for community, learning about community things, because I wanted to leave the medical center to be in the community. After I left, I found a nice little clinic to be a part of, a community mental health center, Coastal Mental Health in Carson, and let's start a little rehab clinic for people with schizophrenia, panic disorder clinic, and depression. We had it was brand new to have homeless services, so we had one homeless outreach worker, and I would back her up sometimes too.
Because what year was that?
This is 1987.
Right. Yeah, homelessness wasn't anything like it is right now.
Right. This is the very first McKinsey money, from federal money to do this with. Or McKinney.
McKinney-Vento, yeah.
And disaster struck my career. Two things happened in the first year and a half of trying to try these new things. One was we had terrible budget cuts. The administration of the Department of Mental Health wasn't very strong. And the other county departments and supervisors said, we just care about safety and emergency care and hospitals. We don't care about community things very much. And they started cutting things in the budget along the way. And my clinic was one of 6 closed. You've never heard of Coastal Mental Health because it hasn't existed since 1990. The clinic just stopped existing. Second thing that happened was that girl who was the homeless outreach worker, her name was Robin Panage, was stabbed to death by a man with schizophrenia in Santa Monica Mental Health.
Oh, I've heard that story. That changed a lot of things.
That's why we have metal detectors. That's why we are in fortress buildings. That's why people are all scared. Not that anyone's ever been killed before or since in working in the Department of Mental Health, as far as I know. But for me, this is a year and a half into it, and we've got terrible budget cuts. We've got hiring freezes. My place is closed. I'm a refugee over at Harvard General's outpatient clinic. My closest friend is murdered. It's like, this career looks like it's about at the end already. Let's just go to Beverly Hills and treat rich people and never mind this. Or let's go to UCLA and just do biological things. Never mind this. But I am kind of stubborn too, so I wasn't ready to give up on my dreams that fast. So is there any way to make this stuff work in the community? And at that time is when the village was first starting and looking for people to work. And I'll pass it back over to David about how they got to that point. And I said, well, I need a life raft from this flailing career. Let's do this for a few years to see if we could do something different. All I knew was we had to do something different. And actually, I want to share a second lesson here for a minute before I look back to the story. Is our very first retreat. David knows where this story is going. Our very first retreat, we had a bunch of staff together, and similar to David's experience, I'm also sitting with some people with schizophrenia who are part of this and going to be the staff. I've never worked alongside anybody with schizophrenia, and they get just as much opinions and stuff, and they're treated as full people there. I've never seen that before. As let's include them. And yes, they knew more than I did. Gail and Alan. And we had a consultant from New York who she played us this old 1970s Sesame Street tape. And this is, I forget, think about it from the Ernie and Bert, which one's a small fat one, but I think that's Ernie. So that one,
yeah,
he wants to play the saxophone. And like the owl, who's like the jazz musician, he's going to teach him. But he's holding on his rubber ducky. Remember, Ernie's got this rubber ducky.
Right.
And every time he tries to play the saxophone, it keeps squeezing the ducky and it's in the way. And in this tape, every celebrity circa 1975 in New York, from Paul Simon to Twiggy to everybody, Lawrence Taylor, sings to him, you have to put down the ducky if you're going to play the saxophone. And she tells us, everyone wants to do something different or something new. What are you going to stop doing? What are you going to put down in order to make space for what you're going to do? In your heart? What are you going to not do instead? And you can't just build more things. There's a limit to money, to your time, to anything. What are you going to stop in order to do this instead? Which my necklace says, everyone can think of what you want to add. What do you want to subtract? This became part of our mantra there, that if we're really going to be about innovations, we have to be about stopping things, not just adding things.
Wow, that's so profound. Yeah.
And so we made this, instead of an employee of the month, we handed the ducky to which staff had put down some old way of doing one. I actually got the very first one. I don't know if David remembers this. For stopping calling people patients. For stopping seeing them just through that lens of all you are as a mental patient. You're just your illness, you're your diagnosis. For seeing them as a full person or as a member of the program, the same way you could be a member of the Y, a member of the community.
I love that. So this was at Mental Health America, right?
Yes,
that's correct.
Which is describe it, because that's the overarching organization that the village was under.
Yeah, we were called Mental Health Association of Greater Los Angeles at the time.
Okay.
Kind of thing, but same organization basically. And just to close the loop on my earlier story, I did get the job. They thought I was overqualified, but I convinced them that I would get the job. And that was my first introduction to the clubhouse model. That's relevant because later on, when we created the village, the clubhouse became a very important part of that. Fast forwarding a little bit to 1988 or thereabouts, as Mark said, things were going to hell in a handbasket in the county mental health system in Los Angeles for a lot of reasons, and a lot of people were very upset about it. There was a man named Dan Weisberg who had a son who was in the mental health system and was not getting the treatment that Dan thought that he should be getting because he was, I guess he had his first psychotic episode while he was at Harvard, had come home, dropped out of school, and was not doing well and was not doing well in treatment. And the story goes that he was told, Dan was told that his son wasn't a good patient, basically, because he couldn't sit still for group meetings, kind of thing. And this infuriated Dan, who was a filmmaker and a magazine publisher. Also, he had some contacts at the State Department of Mental Health. Actually, I think he had contacts in the the Lieutenant Governor's office,
which was Leo McCarthy at that time.
Leo McCarthy had a contact in Leo McCarthy's office, and a group of people went up to talk to the Lieutenant Governor and said, this is an outrage. The system is in a shambles. Heads should roll, kind of thing. And Mr. McCarthy, being the wise person he said, I think people are doing this with the best of intentions. Maybe we should try to figure out a better system rather than just lopping off heads here. And so they created a commission that went around to and examined best practices throughout the United States and came back and said, this is what mental health services should look like. These are the features that we would like to incorporate into our mental health system. And under the leadership of an assembly member from Fresno at the time, Bruce Brosnan, they wrote a bill that was Assembly Bill 3777. We called it AB 3777. And AB 3777 put out a request for proposals for a countywide program, an urban project, and a rural project. And my first experience with all of this was actually I became the community integration director at MHALA in March of 1989. And the first thing they did for the first 3 weeks that I was a staff person there is I was the lead writer of the proposal for the urban project.
So I want to stop you really quick because I was doing a little research on AB 3777. I found reference to that task force that Lieutenant Governor McCarthy had set up. And they had issued a preliminary report in June of 1987. I won't read the whole paragraph. You could actually just say April 2020. Nothing has changed. But the first sentence was, it found that money alone would not solve the problem. Whatever the level of funding the task force charged, the dollars seemed to support the system instead of the people in need. So this was obviously a couple years before the actual legislation was passed. Let
me underline that point because I think it's crucial for applying to today. The system was there as it is today. Clinics, hospitals, emergency teams, ERs, and things. But in the 30 years since deinstitutionalization had happened, people had come up with other things that worked besides the system. The system was just taking the state hospital mentality and putting it in the community. Day treatments, day hospitals, the same people, the same teams. They'd found out that, hey, if you got someone who won't come into the appointments, go out to their office and find them and follow them around. They don't have to be a high-paid person to go do that. That was called an ACT team. Hey, a clubhouse to have a place to come and have purpose and belonging. They used to have these farms at the state hospitals, become purpose and belonging. That's something useful. Hey, paying attention to substance abuse and mental health in the same place. That makes a big difference because the two otherwise are bashing heads against each other. Hey, including something about physical health. That makes a difference. Including some rehabilitative things about supportive employment and where you're not ready to work because you're not all the way well, but we'll teach while doing. Because maybe they're not going to get all well. Let's start by doing things and move up. Supportive employment, supportive housing. Let's do, all these things existed. And they weren't being done anywhere. The difference today is that list is even longer.
What we know works.
We aren't in the same. We have another 10 things to add to that list of things that are working well about peer support and harm reduction and motivational interviewing and person-centered medications and living room crisis programs. The list is even longer than the one that they gave David and said make a program out of. And we still have money supporting the same elements that came out of the state hospital, still wishing that we could have state hospitals and make people do those rather than building a system around these other elements instead.
Which we would define as the psychosocial system as opposed to a medical clinical system in kind of a simple parlance.
And what David did that was really striking and is rarely replicated. almost every other proposal for this, they sent out proposals, said, all right, we'll put the clinic over here. We'll have your doctors and nurses and stuff over here, and your therapists, psychologists, and we'll put the rehab over here. We'll have a clubhouse, we'll do employment things, we'll do some housing down the sides, and the two things have different cultures in different places. That's the way it had always been. And usually the clinical one gets huge piles of money, and this one, if you have a little left over, you get some. Even in Skid Row at the time, there was Skid Row Mental Health and there was LAMP, the two programs running the two separate ways. And what happens is those two do not integrate nicely. They have clashing cultures. They have clashing ways of getting along, ways of getting paid for, who's staffing them, their view of the world. They had said, let's put it all in one building and see if we can work this out. And if I remember right, you were actually worried, are we going to work it out? Is a psychiatrist going to get along with the job person on the bottom with the two floors? Is this going to actually work?
So, let me ask, when the bill passed, then they said they wanted to have an urban project, a rural, and a county. So the village had to compete with others to apply, to be awarded the grant to do the pilot.
That's correct.
Okay.
We had to submit a proposal. We didn't know if it would get funded, but as I said, that was my first 3 weeks at MHA. I was writing the proposal, which, as Mark said, was combining these disparate elements, primarily the assertive community treatment model, which had been shown to be really effective, with the clubhouse model. Those were the two major elements. But of course, there was also the essential service coordination as well. And of course, you also had to, bring in the medical staff and the fact that people need medications and those things. But as Mark just said, they weren't central. They weren't, certain things weren't considered to be central, the medical issues, that kind of thing, and other things ancillary. It was all put together. And we were wondering whether we could make it work, because a lot of mental health services tend to be hierarchical. And we wanted to have a much less hierarchical, much flatter structure. And it required us to find staff who were looking for that kind of culture. That was one of the major issues that we knew that we were going to struggle with.
Would you play pool with your patients? Was one of my interview questions.
Exactly.
Yeah.
And I said, well, I don't play pool very well. How about foosball?
Exactly. But we were looking for people who wanted to do things differently, that were outside the mainstream, and gesturing to Mark, we found them, kind of thing.
So let me understand the notion that it was going to be a per capita budget per person, because you had 120. Originally, it was supposed to be 300.
200.
200.
Actually. So yes, the original proposal that we were supposed to write to was to say we would take on 200 people, and we would be given the payment upfront would be $15,000 per person per year, which I just looked up, roughly in today's dollars would be about $33,000 per person per year.
Which is not a lot of money.
Not
a lot of money in the conventional system.
No, that's right. But the what you need to know is that you could argue that it was even less than you think, because we were also at full risk capitation. And what I mean by that was, unlike most programs at the time, or any programs at the time, if one of our members was to go into the hospital, we would be responsible for that cost. So Mark, as a treating psychiatrist, would follow the person into the hospital. You can't imagine the continuity. I'll let Mark speak more to that, but the continuity that allows you, but it also provides a certain fiscal responsibility, because you're on the hook, for those hospital costs. So that was the original requirement, was 200 people, $15,000 per person per year. And we were responsible for all the mental health costs for that person.
And we couldn't disenroll anyone. It's a no-fail program.
And so there was the pilot group, and then there's the control group who stayed in the normal and customary mental health system.
Carrie, I forgot to mention that unlike most studies, there was what's called random assignment to conditions. So originally it was supposed to be 200. That got blue penciled by the governor, Deukmejian at the time, said, we're not going to do this for 200 people. We're going to do it for 120. So they cut our budget by 40% before we even started, kind of thing. But the state then hired an evaluator to actually study the people in our program versus those in a control group. And unlike most community studies, this one actually had random assignment. So we had no control over who was assigned to the village versus who was assigned to the control
It could be
group.
a whole range of severity of mental illness.
That's
from
correct.
moderate
Actually,
to
we were mandated to take a whole range of severity. The group had to be at least SSI level of disability or worse.
Mm-hmm. So that's a scary thing. I calculated it's $1.8 million, which is not a lot. You have to hire staff. You have to possibly pay for hospitalization. You have to pay for pizza or whatever. So talk about how you envisioned, and did you include the staff in understanding, like, this is all about optimally serving people at the lowest possible cost. Was that baked into the staff culture at the beginning? Did you know how you were going to approach that?
I don't think that we spent a lot of time. I mean, we made it clear to people that it was a capitated system and that we were getting a certain amount per person, but we very quickly, coined the phrase, whatever it takes with people. So what we found was that it wasn't that hard to treat people out in the community kind of thing. Mark could speak more to that.
Tell some stories about how that played out.
Let me try this one because, so I was very much afraid we were going to go broke. Because everyone else who had tried this had. There were some other programs in New York that had gone broke trying to do this. Every kind of capitated managed care tries to get rid of these people with serious mental illnesses. They never try to let's put them together and serve them. That's a recipe for financial disaster.
Can I halt you for just a second, because this is the funny thing. I was worried about it too. And when the governor blue penciled when we went from 200 to 120 people, I told our then CEO, Richard Van Horn, I said, Richard, we can't do this. So it won't work. We'll go broke. And he said, are you crazy? We're doing this kind of thing.
Bless his heart.
Yeah. Bless his heart.
Yeah.
Yeah.
Actually, let me do one quick comment on what the reason it got cut. In my view, the main reason is because the regular system said, don't do something new. If you got money, give it to us. We're short of money.
Wow.
Was where the competition
because that's important. This money came from the state budget.
Directly.
Yeah.
And they said, if you've got money to give to mental health, give it to us and the counties. Don't go giving it to specialized little programs. So I'm sitting there, and we've got these hospital contracts, and I know if I put too many people in the hospital, we're going to go broke. So our team meetings end up looking like, so-and-so is struggling. If we put them in the hospital at that point, we'd negotiate a $350 a day to go there. Now it's well over $1,000. And we said, is there anything we can figure out for $350 that would work better and would be less? We weren't trying to be just cheap as well. We were trying to be better, actually.
Right.
And we said, well, actually, I'll give you a short thing. Like, somebody wanted to go to the hospital because his brother was going to move them to New Orleans, and he was too scared to go, and he wouldn't tell his brother. I said, well, I'll let you spend a day in the hospital if you want, but only if you agree to have a family meeting to work this out. He comes back and says, well, how about if we just do the family meeting and I don't go to the hospital?
Touché.
And I stayed late and did the family meeting. I brought shots to people's houses when they were paranoid. I remember me and the assistant director climbed up this ladder under the third-story window where someone was paranoid and hiding off, making sure his head and brought some. I remember dumping someone's beers out into the sink and doing alcohol detox in their place, hiring others of the members there. Hey, hang out with your friends, and here's some money for a pizza, and hang out together so they're not lonely and suicidal today.
Wow. We
could figure out lots of alternatives for these things. We did it so well. They would probably know the numbers, but we cut about, he had put aside, I don't know, $800,000 for his hospital, and we cut it to like $300,000. We used that the first year. We use that money to buy an extra substance abuse person, an extra money manager payee person, an extra employment person, extra social community integration person.
So you actually had set aside the budget for hospitalization because that was the default way and continues to be the default way to do this. Did it surprise you that these results were actually showing such a divergent pathway so quickly? It did surprise us a little bit.
I mean, you have your hopes, Carrie, that things are going to work out the way you plan them, but you don't know until you try it, actually. And so it was a scary time for us at the beginning. But as the evaluator found, after after 3 years, I think the amount that they said that we saved over the comparison group was around $300,000 in hospital costs versus the comparison group. We just had fewer hospital inpatient days, and we sort of had close to the same number of stays, but we were able to get people out of the hospital a lot faster.
Actually, sometimes it was faster, sometimes it was slower.
Sometimes it needs to be a longer.
We knew what we were doing with the person, so it wasn't let's change all their meds. And they come out and they're hauling different meds, a whole different person. We'd admit them with an actual purpose in mind. Mm-hmm. We got to get them back on their meds. We got to clean. We got to figure out what to do about. One way I put someone in for a cataract surgery because we was always bouncing around drinking on the streets. What are we doing this hospitalization for, and what support do they need to get out? Because of the capitated system, the hospital was working for the community services rather than being imperious on their side, doing whatever they wanted and just billing. We lost that after a while, but that's an important lesson is this hospital will resist we might call that expenses. They call that income. Mm-hmm. They will resist it being taken away unless you give the power of the purse to the program. Us having the capitated money that literally paid the hospital made them work for us.
Interesting.
When that stopped, they stopped working for us.
And that goes back to your point about integrating everything together in this holistic way.
Even the hospital's integrated. Yeah, and that's important, and that's why the capitated funny, because people have real trouble using fragmented services. If you've got here's your clubhouse, here's your hospital, here's your doctor, here's your voc rehabilitation, here's your substance abuse program, they don't make it to all these things. That doesn't work. The full name of the village was Village Integrated Services Agency, to put everything in one place.
What also seems interesting about, as you're starting to talk about how you approached living within that budget and trying to enhance people's lives, is that you were changing the playbook as you went through. Because I would imagine it'd be very hard when you're writing this proposal to predict exactly how this is going to play out. You had to actually get in and start to do it. And you had the discretion and the ability to do that. So what are some of the maybe assumptions you started with that changed over the course of the actual implementation?
So one of the things that we knew that we had to include, it was required as part of the proposal, was the service money management for the folks that we serve, because a large number of them were required to have a payee. And so one of the services that we included was money management services for people who were required. Some people who could use it, they weren't required, but they needed help with money management, so they could take advantage of that as well. So we included money management and we had the village bank was the place where that took place, where people could pick up their personal and incidental money and have their bills paid for them if that was required. But one of the things that we wrote into the original proposal was having the person's personal service coordinator, that was the common term is case manager, act as the person's money manager. That was my idea. It was one of the worst ideas that I ever had. Because money is a contentious issue. And when you're the person who has to say no sometimes to somebody, you don't want that to interfere with the more global aspects of the relationship with somebody. So I'm not sure how long it took us to implement that change, but we had a program money manager who I jokingly referred to as the most hated person in the building, because that person made all of those,
tough love
decisions for people. So that was the kind of thing, is that we would find out, well, this isn't working quite the way that we had anticipated.
We're going
to
still
pivot. Need to provide the service, but how do we adapt?
Let me add a little to that one from the staff's point of view. The other problem is, if you're the case manager and you've got control of the money, just like any family member would, any parent, you try to use it for their best interests. You try to control it. Well, I'll give you this money if you do this thing good with it. And you get into all this stuff
negotiation
of the money, trying to use money as a therapeutic tool, which, as any family knows, does not work and makes this giant mess. The money manager was, how's the rent getting paid? Are you getting food? What are the bills? Do you want a phone? What's happening with the money? I'm not here to stop you from using drugs. I'm not here to have you buy good things with it. That's up to you. And the case manager would if they wanted to use money for things, spend our own team money to buy them school books or a rehab or something. But weren't tempted to use money in a manipulative way to help the person, as most families are.
Yeah. So to that point, I was reading a little bit of something you wrote about this, Mark, and you had mentioned some of the guiding principles that imbued this pilot. One was, you already mentioned whatever it takes, but the other three were choice, quality of life, and community focus. Can you elaborate a little bit about how those guiding principles were kind of played out?
Yeah. So the standard medical psychotherapeutic model is, you come to me, you've got some problems, I make a diagnosis, I feel it's wrong, I tell you what to do. I will give you informed consent. Here's the things, let me explain what's going on. And then I check to see if you complied with what we're doing. How did it work along the way? That's a standard contract. That contract falls apart for almost everybody after about 2 weeks. Think for yourself, when the doctor gave you pills for your ears for an ear infection, you didn't even make it through 2 weeks. You're, I had enough, I'm feeling well, I'll put it over here, maybe I'll need it later or something. Let alone if you look at people taking blood pressure pills for a number of years, it goes away. If you want something to last for more than a couple weeks, you have to switch from that acute medical model of we're telling you what to do into a longer-term collaborative model that empowers the person along the way. People won't do something that isn't their plan. What is your goals? How do I fit it in? So if you're taking medicine, it's not because I'm telling you to do it. It's because you have a goal. For example, say you want to be able to hold an apartment, and at nighttime you're ending up screaming at people all night long. So you might be willing to take some meds at night to be able to keep your apartment. If I say you better take these because you have schizophrenia and a dopamine imbalance, you may or may not take these.
But if your goal is to be able to be successful in that,
I remember one lady was incredibly stubborn. She wouldn't take any medications. And this is actually one of the learning things fits in this story. One of the things I had learned that first you get your illness taken care of. You got to get your pills taken care of. You got to get your symptoms down. You got to get your substance abuse down. You got to work through your emotional trauma things.
That's the conventional way.
Right. And that's what everybody's taught. And then you do something else. If you get good enough, we can talk about some rehab. The job employment stuff is for like the 5% of people who manage to do the best or something. We gave job employment people to 70% of the people, and they were at SSI level disability or not. You didn't have to get better to do this. And it turned out that people do it backwards. Wanting to have a life makes you more likely to follow through with your treatment than getting good treatment makes you want to have a life.
Wow, you should say that again.
I'll tell you the story where I learned this one. So this lady, she was terribly non-compliant, spoke only Spanish. With all spiritual stuff, she believed God was talking to her. She was praying holy oil on her elevators, making this big mess. We put her in a little apartment. She took the refrigerator and threw it down the stairs. I don't know how she did that, because there was demons talking in the back of the refrigerator and stuff, and wouldn't take any meds or anything. And it's just going terribly. We tried putting her in the hospital and make her take meds. That didn't work. That doesn't really work.
She's in your pilot. She's using up money.
Yeah. Well, it isn't the money. Yeah. If it worked, fine. It doesn't work. She comes back out the same as things before. But what she wants to do, she says, I want to donate money to the church. And her Social Security money, after you paid her rent and they gave her other money, when she talks to the money manager, there's not enough money to donate to the church here left. So she says, can I have a job washing dishes to make money to donate to the church? Any normal program would have said, sure, we'll give you a job washing dishes as soon as you start cooperating around here a little bit. Take your medicine, start following through, better take care of things, do our little job training program, and then you can wash dishes. But we turned that readiness upside down and said, if you're motivated and excited, go for it. Give her a job washing dishes. And she's every bit as stubborn washing the dishes and stuff. But that isn't really the point of the story. The point of the story is she comes back to me the week later and says, I notice I'm washing dishes. I'm having trouble focusing and concentrating to what I'm doing. You're always trying to get me to take some meds. Do you have any meds that might help with focusing and concentrating on work?
Wow. That's
sure,
amazing.
Here's some Haldol that'll help do that.
Yeah.
This is an old story, so it's an old pill. the meds fit into what she wanted in her goal of life, not first she took the meds and then she wanted a life.
This is so Trieste. This
Over
is what we
and
saw
over.
over there.
It is, Carrie. It made me think of another member. His name was Eugene, who had a lot of psychotic delusions. And we were being visited by some medical staff from some programs in New Zealand because they had heard about the program and they wanted to come over. And one of their psychiatrists, talked to Eugene and was, quite impressed by, the level of his delusions. And at one point, Eugene told him, well, you'll have to excuse me now because I have to go answer the phones for the village, the receptionist kind of thing. And the psychiatrist couldn't believe, he said, oh, this will be interesting. And so he sat down to watch Eugene answer the phones. And every call that came in, he was perfectly professional because it was important to him to have this meaningful role. And that's really what Mark is talking about, is like meaningful roles are something that the mental health system does not help very much with the people that we serve to achieve. And I think that was one of our signature achievements at the village, was helping people to identify and then to try to move into and accomplish those meaningful roles.
Before I want to say one last thing about this is the other thing that goes backwards from the way it's the same way is sobriety. You don't have to be clean and sober before you work as a receptionist or before you get an apartment either. Working as a receptionist, having an apartment is what gives you the motivation to be clean and sober in order to hold it. That one goes backwards from the way we think too.
And lest your listeners think that, oh yeah, but how are they doing on the jobs? You still hold people to the standards of the job. Okay,
that's what I wanted to talk about, is that if this is a perfect segue into the way you fashioned work opportunities, both in terms of, sounds like, helping with the reception, washing dishes, but you also started some businesses that might even still exist. Can you talk a little bit about that?
Sure. The clubhouse model really is about vocational preparation to some extent, is helping people to get ready. So we actually had jobs within the village. At any given time, you could see 35, 40, 45 members working in various jobs. There was the cafe, the village cafe, where people could get jobs there. The custodial services around the building were done by members, as well as all of the, as I was just saying, the clerical and, phone answering and that sort of thing. So that was sort of the introduction to people, and they were, paid, minimum wage. It wasn't a sheltered workshop or anything like that. People were held to, the standards of the position. But the idea was that there would be help to then find jobs out in the community as well. And so we actually had job developers and job coaches on staff that would actually develop jobs out in the community. Our original, employment services director, Paul Berry, was just amazing at being able to find businesses out in the community that we could then go out and, sell our members to. And he was always very insistent. It's like, we're not selling a disability here. We're selling good employees kind of thing, because as we know all right now, it's like, it's very hard to find a good employee to do the work. And so what we were doing is we're training people, helping them to develop a lot of the skills that in a lot of cases, because of their psychotic disorder, had not enabled them to develop. And now we're able to actually go out and do that. But they still needed the help to both find the job and then provide the support while they were on the job.
Let me tell one quick story about my learning of that as a psychiatrist. And Paul comes to us from having run a cookie store, corporate cookie run by people with mental illness.
Yes, I remember Corporate Cookie on Wilshire Boulevard.
Exactly.
Yeah.
And so, Paul, we've got these people when we first started, and they're working little stipend jobs, about 3 hours a week to make sure they don't disrupt their Social Security, and they're doing it crappy. But, they got terrible mental illnesses, as good as they can do. That's just fine. I'm like, good. Paul comes and says, well, we're not doing it this way, these little jobs. That's not practicing or learning anything. That's just, practicing missing free throws. Let's make every job is 5 days a week, at least 2 hours or 3 or 4. We'll work with the Social Security stuff with the deductions, because you end up with more money even while you're working part like that, but you have to work through the paperwork. we'll have them do this thing, and we're going to hold them to community standards. They have to do it right. And I said, that's the stupidest thing I ever heard. These people can't do this job. They have terrible you must never have worked with people with real mental illnesses like I have and stuff. But since the psychiatrist doesn't run the job department, the job Paul did, we did it Paul's way. And sure enough, within weeks, he's firing all these people, and I'm ready to walk up to his office and say, I told you so. But the strangest thing happens. Mm-hmm. These people then come down, and they want to get their job back. And we're scrambling around. Well, maybe you got too much meds in the morning, making you too sleepy. Maybe you need to take a little more antipsychotic. Maybe you need to not get drunk every night on these things. Wait till after work to get drunk. Maybe you have to do, and you have to work on your social anxiety. We're working on these various things and getting their job back again. And then he's firing them all when they're not making the thing. And we're getting a job back. And he called this work hardening. I called it frustrating. But after 5 or 6 or 7 times, these people who couldn't do anything were now working to community standards and proud of themselves and workers and starting to incorporate this as their identity and who they are and ready to be working on the outside of these same standards, even though I knew it wasn't possible because they're too sick and you have to take care of their sickness.
I mean,
first.
That is such a profound example you went through, and how you could have jettisoned Paul and said, this is just too radical what you're proposing here. What was that like?
Well, and you'd be surprised.
Paul was more than I was. So.
It was hard for everybody to wrap their head around that idea. That was the surprising thing. I remember getting a call from the then director of the Department of Mental Health who said, "What's this I hear about you firing all these people?" kind of thing. She was very upset. And I had to explain to her, we're attempting to do something here that hasn't been done before, and it may take a little time, but we think it will work out in the long run. And I think it did. We discovered for ourselves that people are capable of what you ask them for. I'm not sure who originally said it. I think it might have been Martin Luther King who talked about the soft bigotry of low expectations.
Mm-hmm. That's a powerful statement.
And I think that's been
very true in mental health.
That's been the standard feeling in mental health. And I think at the Village, we learned that we needed to get away from that.
So let me do another lesson thrown in here about how things are financed or bureaucracies go. We might have said the one what the hospital fell apart.
Right.
This one fell apart too when we started taking money from the Department of Voc Rehab to pay for these job sites because they don't like firing it up and back and up and back. They just counted you hold people for 6 months of the things. They don't want it going up and back. They don't want things. It isn't set up to support that system. And so we had to stop doing this working thing because it didn't meet the criteria of the payment that came to support their outcomes rather than what the people actually needed.
That's so frustrating. Wow.
There's examples all over the place. When people say, why can't we do these things? There's reasons why these things deteriorated as you tried to plug them into the system that distorted the system wouldn't change. Yeah. We had to distort and not do what we'd already didn't work, and they put us back to the things that didn't work.
If I remember correctly, the Department of Rehab couldn't get its 26 closures. 26, not the number of closures, but that was their code number. Was a code 26 was for when you kept somebody employed for 90 days or something like that.
Just checking a box.
Exactly.
It's really not thinking about the person. Yeah. That's what I find so remarkable about the pilot you were involved with. You were able to exercise discretion, and you were able to be creative and to be nimble as opposed to following the prescribed way of doing things that a typical government program would require.
So this is a crucial piece. We were a set of people who we took responsibility for all these things and shared the responsibility. And now we knew we were in this together. This was our program doing together. We took pride in the things and doing what happened. And we did it by relationships and working things out. People came by as the years went on. And by the way, one thing David did mention, that outcomes of that research study, we had the best outcomes across the board for unselected people and quality of life outcomes that had ever been reported in any group, and much better than the control group was.
So I do want to talk about the outcomes because it was studied. We're starting to hear, obviously, it sounds like more people had jobs, less hospitalization, but what were the salient outcomes from the Village pilot?
So, I could give you the numbers. for example, in that first 3 years, nearly 3/4 of all the village members tried employment, for example. Now, it's not that all of them stayed employed or anything like that, but nearly 3/4 of them actually tried paid employment over that period of time. That's just unheard of. That was compared to in the control group of about 15%.
Wow.
So 5 times as many people, were trying employment. It speaks to the power of meaningful roles and what that means to people, and what if you provide them with the opportunity to do that, they will take it. The number of people living in group settings declined at the village from about 16% at baseline to about 11%.
That'd be like in a group board and care home.
Exactly. While it's remained constant for the same level for the people in the control group.
And that's because more of them got independent living, right?
Exactly. One of the things that we discovered was that the biggest impediment to people living independently in the community was they couldn't get first and last month's rent. So when you were able to give them their first and last month's rent, it's like all of a sudden the barrier was lifted and people were able to go in. Again, about the flexibility of the funding. It's like we were able to do that. Village members reported more solitary leisure activities and more activities with others. And village members reported significantly more support at each of the 3 individual annual interviews. And this is pretty significant as well. Families of village members reported significantly less burden and less stress from burden than did the family members of the control group. They also were more hopeful about the outcomes for their family members than were the family members of the control group. And finally, members of the village were significantly more satisfied with their services than members of the control group. Yeah.
So now that begs the question: this remarkable pilot ends 3 years later. 3 years, the independent evaluator presents these pretty stellar results, and State of California says, "Well, thank you very much. That was really interesting." Or what happened next? Because you would think this would have informed big system change.
So we actually were under the same capitated system for a 6-year period of time. We opened our doors.
So they extended it.
July.
Oh, okay.
They did. We opened our doors on July 1st of 1990. And it was the same capitated system through June 30th of 1996. So for a 6-year period, we conducted this ongoing study. At that point, the state of California said, "This is great. We really like what you did. Everybody in California should be doing this. Now we're going to stop the state funding, and you have to do it using the same system that everybody else is using, which is the Medicaid system." And for your listeners who don't know, it's like most of the services in the state of California for mental health are funded by a local 50% of the money comes from a local match, and 50% comes from the federal Medicaid dollars, in California referred to as Medi-Cal. And that's the primary funding source. And that's what we started adopting on July 1st of 1996.
And those federal funds have really strict parameters and limitations.
Exactly. It's there. What I neglected to mention earlier, Carrie, was that although we had documentation requirements, and Mark could speak to this as well, it's like they were minimal compared to those standards that you're talking about for Medicaid dollars, is that the amount of documentation that our staff had to do was basically monthly summaries of what was going on with their members
and tracking outcomes.
And tracking outcomes. That's the important thing. We had to be, reporting, are people getting employed? Are they going back to school? Those kinds of things as well. None of that happens in our current system. But on July 1st, 1996, that all changed for us. And we became a part of the same minute-by-minute billing fee-for-service system that everybody else is doing.
And for the average staff, that generates about 2 hours a day of paperwork.
Wow.
Right. So, yeah, up to now, people make the case that somewhere between 30 and 40% of a staff person's time will be documenting the work that they do, unlike anything that we had experienced. Now, in our arrogance, I think we didn't realize what that would do to us. We had spent 6 years building this culture that everybody felt
whatever it takes
good about. And we didn't understand how that would impact us. But
do you remember the first decision you had to make where someone said, oh, I'm going to go do this? And because they used to be able to do that. And then you had to say, no, you're not going to be able to do that because there's no way we can pay you for that.
It doesn't play out like that. It plays out that you must, instead of just being given the money, you must generate billing. So you have to show any given day that 5 or 6 hours a day is in billable services to generate the match, to be part of your budget. You can do whatever you want, but you get in trouble for not doing enough billable things. So that what this looks like is you're behind on your billing. Get behind that computer. I don't care who shows up, and spend the next 4 hours catching up on your billing.
And I'll also add there's a negative incentive in terms of showing growth or improvement in the people that you're serving, because there's always this underlying assumption, well, if the person's doing better, do we really need to be keeping them? Are they ready to be discharged? And you don't want to be over providing service. That's not what I'm.
But you got to keep the doors open.
But that's right. But there's got to be this ability to say, yes, this is where the person is making improvement. This is how the person is recovering. But you start to create fear around actually documenting that, because you're afraid that somebody is going to say, well, this person doesn't need to be in the service. Let's discharge them, kind of thing.
I remember one person. I would let people read their charts if they wanted to, as part of being rewriting whatever you want to do. And she read, I don't like all these notes. Everyone makes it sound like there's something wrong with me and I needed your help to get better. How come you never give me any credit for anything? And I said, you want to know why that is? Because we don't get paid for you getting help for yourself. I have to make it sound like I did it rather than you did it.
Oh, my gosh. Wow.
So let me do a moral for the current system. We knew this. We knew those problems. It was struck us badly. And when we set up the Mental Health Services Act, it was set up to say you weren't supposed to supplant the stuff existing. You weren't supposed to put it in Medi-Cal, but it was supposed to be for these things and pay for other things. So you can do the doctor time is not that hard to document for Medicaid, and some things aren't. But a lot of these other things are. So use the Mental Health Services Act and use Medi-Cal for the other stuff.
So let me press pause for a moment for people who are listening, who you just kind of jumped ahead to 2004, right? Mental Health Services Act was the millionaire's tax, Prop 63, and was partially informed by the village pilot. Heavily. So from connect the dots there.
So in 1998, Assemblymember Darrell Steinberg, because of the homelessness situation that he was experiencing in Sacramento, wrote a bill, AB 34, to try to take what we had learned at the village, basically, and in some other programs that in LA County that had tried to adopt this as well, and to make that a statewide program. And actually, there were 34 counties and a couple cities that actually implemented that from 1998 to 2007. And because of the results of that, based on what the outcomes that program got, Darrell and Rusty Seelix from the California Council of Community Mental Health Agencies wrote Prop 63 in 2004 that Mark was alluding to, that said we are going to use the lessons that we've learned from these programs and build it into the entire system. People might have heard it referred to as the millionaire's tax, that 1% of all income over $1 million goes to these services.
And this is to come up with a new source of money that would be flexible enough to do some of the things.
Because by then, we weren't naive anymore. We had seen the deteriorations, and the same thing we said, we need to have some money that isn't coming through Medi-Cal.
And so has Prop 63 borne out the promise that was envisioned at that time?
Yes and no. There are programs that would have never existed without it. There are full-service partnerships that never existed.
What is a full-service partnership?
So basically what David described, that the village was in effect the first and largest full-service partnership. This combination of people at very high need who get the assertive ACT teams, services with the case management and the intensive services in the clubhouse setting with all the services put together. That's what a full service partnership was supposed to be. And half the money goes to those of different age groups. You can use for kids or transitional age youth or adults or older adults. But when the recession comes in the 2008 or so, the money is drying up locally. And almost everybody says we've got to double this mental. If we spend one, we can spend $1 on some of these things, or we can put it into the Medi-Cal thing and get one from the feds and have $2. We need this for the budget. And as a result, all the flexibility was taken back out because the money was all matched. It doesn't have to be, but no one's willing to give back some federal monies in order to get the flexibility that would make it work. They'd rather have twice as much of what doesn't work
to pay for what
instead of $1, instead of half as much of the things that could supplement it working. I'm okay with two funding streams, but they took this one that was designed intentionally because we learned all these things, and everywhere said, nope, we're putting that over there because we really want that federal match.
And it's hard to unravel that. Take that genie and jam it back in the bottle.
Yeah, it's it's hard to convince policymakers to consider the fact that it's the way that we pay for things that gets in the way of providing the services. And it's really important, Carrie, that you understand, or your listeners understand, that Mark and I are not against accountability. It's like when we rail against documentation and that sort of thing, it's not that we're not trying to hold ourselves accountable. We just think that we should be held accountable for something else. We think we should be held accountable for the outcomes of our services, not about whether we dotted the I or crossed the T. And that's where you need to consider payment reform as the way, because that was the essential element that, as I mentioned earlier, in our arrogance, we didn't realize how crucial a factor that was for helping us to provide the kind of culture and the kind of services that we were able to do in those first 6 years at the village. And unless we're able to create a system that has that kind of flexibility, I think we're just going to be hamsters in a wheel, just turning over the same thing over and over again.
So if people listening to this walk away with anything, this notion of payment reform is fundamental to actually making the bold changes that we need to our system.
It sounds like the most,
unsexy.
Yeah, it's not, but it's crucial because everyone will choose to do what you get paid more to do, whether it's the most helpful or not. That makes it your thing payment driven instead of client driven.
So as we come to the end of this time, I want to just
actually, I'm sorry, before we run out, I want to tell one more lesson.
Okay, but I want to talk about recovery. That's where I want to segue into recovery for a moment. But go ahead, tell me about the lesson. All
right, I'll see if I can make the lesson segue into recovery. This is even after we're full service partnerships and it's set up. Anytime you set up a good program or the program is helpful, it gets filled up. And then you say, well, it's full. We need more. And they get tired of giving you more and more money for things. If you set up a nice homeless thing with 30 apartments, the 30 get filled and you still have just as many people coming because this is a river of people coming through. Every project has to have flow. People have to move out as well as coming in, or whatever you build, good or bad, it gets filled. So we struggled a lot with this concept of flow, and this is already in the recession and after the recession. How do you decide who should flow or how to do this? What's better and what's worse? And it's what we learned was don't use the old "how are your symptom checklists doing." There are basically two premises, and we try to make tools around this, but two premises. One is, how many protective factors do you have? Do you got some money in your life? Do you got a place to live? Do you got some family connections? Do you got some other adult connections? Do you got some purpose in life? Do you got some spiritual connections? If you got those things going on, when something bad happens, inevitably bad things happen, you won't fall apart. You can get away with less intense services because you've got protective factors. I would wager, and I'd love to see this study someday, if you go to the ER and say how many protective factors do they have, that they've all got one or none. Nobody's there with all five of these things going on. The second way of looking at it is to say, did you stabilize your life and get better because you learned how to do more things on your own, or someone was providing it and taking care of you, doing it for you? The more that its people took care of you and did the things, then when you lower the services, it falls apart. The more you were taught, the more you can do it on your own. And so back to remember those notes that I took care of everything for. The more you take care of things, the more flow doesn't happen. Any parent knows this too, that if you do have how the parents, your kids will never grow up and leave.
They'll never leave your house.
It may be easier over the short run. But it's not just the payment system like that. The liability system looks like that. Did you take care of it? Why did you leave that to theirs? How come you let them make mistakes? The professional ethics look like that. And the way we're trained, you take care of, you're the doctor, don't let them make mistakes like this. You go for and do things for them. That the more caretaking you do, the less people will be able to flow and move on. So you have to look at what did they learn and how did they grow, and did they have protective factors? Then they can move on. And if you don't, people hate this moving on thing. Families hate it, staff hate it, the people hated it. Hates this flow and graduation. But imagine no one ever left second grade. The second grade class would be filled in a couple of, what are you going to do? You have to have flow between grades. You have to have graduation. Otherwise, all you have is dropouts and failures. To build that in requires that the funding and ethics and liability go with that. It requires that the professional training go with that. Requires that you stop taking care of people and doing, and you focus on building those protective factors so when something does go wrong, they have resilience and you haven't created a disaster.
And they can come back.
They can come back. That's the worry. I think people, if they go independent, what if there's a setback? There's got to be a way back.
Exactly. Yeah. The door swings both ways. People, but Mark's point is essential, is that when we first started the village, we had no concept of recovery. That came in not much later, but later. But it was a very tough thing, because when you've seen people at their worst, you're worried that, if you cut them loose, if you let them go, they'll fail. And, that doesn't happen a lot, but when it does, you have to have the capacity there to say, okay, learning lesson, come on back, we'll help you again.
Right. Yeah. So the recovery notion, I know you've taught me a lot about that, Dave, because at the beginning I used to think, how does one recover from mental illness? It's not like recovering from a heart attack or whatever.
It's like recovering from a heart attack.
But I've come to understand it's about reclaiming your life and what's possible and potential. And that's kind of what we need to believe in as we seek to envision a new mental health system in America.
So let me say a few things about recovery, because I ended up very engrossed in this feeling liked it a lot. One, remember I was talking about we were worried about how these people would get along and the lack of hierarchy and it'll be a clash. Is the doctor going to get along with the thing? Recovery is the model that integrates all the staff and we are all working together to recover, rather than I'm doing treatment and you're doing rehabilitation. We're both working to recover. We adopted it early on as a practical value set so that we could all get along and not have internal fights and internal fragmentations. Recovery requires recovery is the
North Star.
Yeah, recovery requires three things that are different than normal. One is you switch from illness-driven to person-driven. So the illness doesn't recover, the person does. Take your heart attack there. I've had a heart attack. The heart attack muscle didn't regrow. It's still back there. I recovered my life. I recovered, even the heart didn't. I can recover from schizophrenia even if I'm still hearing voices. If I recover my life. Recovery is something the person does, not the illness. So your treatment plans have to be person-driven. Your services are person-driven about your whole life. It's more about, do you have hope? Do you have nice natural supports of things? Can you handle things? Are you resilient? Do you have purpose? Is your life rebuilt? You recovered your life. You didn't recover the heart muscle. The second thing that's different is recovery isn't something somebody does to you. You recover through your own efforts or collaboratively. Therefore, the services have to be client-driven, collaborative instead of professionally delivered. I can't recover you.
Wow.
I have to drive you in recovery. So that's it. And most professions are driven, I'll do something to you. The third difference is you don't recover because you get rid of all the things wrong with you. You recover because you build resilience in life in spite of the things that are wrong with you.
Wow.
That you can handle things even when the inevitable bad thing happened. You recover because you built your strengths, not because you eliminated your weaknesses. The man Dave was talking ways back about who was working the job. He didn't hold that job because he got rid of his delusions. He held that job because he built self-responsibility, caring about what he's doing, the professional mannerisms, being taught how to use the phone system, showing up at time well dressed. He built his strengths rather than eliminated his weaknesses. Those three transformations, from illness-centered to person-centered, from professionally driven to client-driven collaborative, and from deficits-based to strengths-based resilience, are the keynotes of any recovery-based program, and every program has to look like that. And every funding source has to look like that, and every HR risk management has to look like that. That's the North Star of these things, because what we have at best in our system right now is line staff at the bottom trying to do these various things, rebelling against the things above them and fighting against them. And yes, there's plenty of rebels in mental health services, especially if you start working in homeless services or in jail or transitional age youth or all the places I like hanging out. But you're not going to make a system out of just people rebelling against the system. Once you try to get it to, we're not rebels, we're not outside revolutionaries throwing bombs here, we're not Che Guevara's here. What's an inside reformer? What's the Nelson Mandela, building things from the inside? Then the recovery values have to go from the top all the way to the bottom, because you can't expect people to be rebelling and expect that to make, it's like weeds. It'll keep popping up because it keeps working, and you'll hear people doing new recovery things all the time. It's very hard to get rid of it entirely if you're the system trying to get rid of this. But it won't grow to be the whole thing so long as it isn't embedded in all the way around. And we spend a lot of time building tools for the system. We built outcome measurement tools called the milestone recovery scale. We built recovery-oriented supervision things for the team leaders, and then we built this kind of capitated funding thing, so the funding would look like all these structures. We even sat once for hours and hours making a set of policies and procedures for staff-client relationships at the county, of how you interact on the harm reduction and the stuff. Remember, we spent hours doing this.
Yeah.
There are infrastructure things you can build, but those don't grow back like weeds. Rebels aren't bigots sitting building policy.
So with that in mind, it's so beautifully said. And for the people listening, who I really do try to speak to a lay audience, policymakers, people who are advocates, I'm sure there are people in the system listening, but I'm trying to help equip and arm people like me in the community to be more vocal and to ask the right questions. What encouragement would you, I feel like there is growing awareness about these issues. There's growing dissatisfaction. 35 years later, we still see the exact same things that are articulated in this report that was written. What encouragement can you give to people listening who might just say, gosh, if we just can't seem to get it right? Do you have a sense of hope or optimism for what awaits us, and what role can people play? Maybe start with you, Dave, and give Mark the final word.
So I used the word unsexy earlier about payment reform, Carrie. I don't mean to sound discouraging, but I really do believe that unless we are willing to look at how we hold ourselves accountable for the services that we provide, is that we won't change very much. Accountability is usually thought of in terms of keeping people from committing fraud and those kinds of things. We weren't concerned about that in the first 6 years of the village. It's like nobody was worried. We had an outside evaluator who was looking at us all the time and interviewing us. It's like no fraud was going to take place, kind of thing. But we were held accountable in a different way. It's like, are you actually making a difference in the lives of the people that you're serving? And so unless we ask that question, and unless we provide the tools to be able to answer that question, I don't think that things are really going to change. We have to be willing to take a leap of faith here and say, okay, we're going to let go of some of these onerous requirements because we're going to try something new. And it doesn't have to be on a big scale. I would love to just have the opportunity to experiment with these things in the same way that we experimented 30 years ago and say, let's see what we can learn and try it on a smaller scale and see what kind of results and what kind of outcomes we get. I certainly don't think we can do worse than what's happening right now. So that would be my preference, is to actually take some of these lessons that we've learned from this around freeing up our staff to be the best people that they can be, because staff are craving these things. They go into this field and the people like Mark, people who have served this population, are saints. They are some of the best people in the world, and they want to do these things, and they're being held back from it. And they're suffering burnout because of that. And so if we can free them up, they will benefit, and the people that they serve will benefit, and we'll all benefit because the system will be so much more efficient economically and financially as well.
I think them listening to you, they'd have a big amen for that. Mark, bring us home.
I'm not so sure about the saint part. The narrative we tell is that we closed the state hospitals, we didn't give the services, people ended up in the streets, we need to have more medical treatment. It's not a failure of our treatment or our science, it's a failure of money and politics. That isn't right. We brought the medical model out of the state hospitals, the same teams, the same accountability structures, the same liability, the same professional things, and it didn't work in the community instead. There is a viable alternative. Recovery is every bit as comprehensive a system can be put together. There are answers for all these things, but it cannot be implemented by the standard medical model system. And the four things that need to be attacked the most by your average listener is people with mental illnesses, even severe ones, aren't hopeless. People do get better, and when you spend time with them, it makes a difference. This isn't just wasting money. Even with our current system, lots of people got off the streets last year. Lots of people are recovering, but it's the river more take their place. Second thing is, you don't need to be frightened of all these people as much. We don't need to have police out there with guns and all these things. We can do other things with the 988 system. Don't have everything locked. They can make mistakes just like the rest of us. What's different is their protective factor, so it turns out worse. We can be curious about their lives. Third is, you can relate to people with mental illnesses. You don't have to say they're ununderstandable, they're crazy, I can make a connection, leave this to the professionals. We can connect to people, and connecting makes a huge difference. Peers connecting, volunteers connecting. There's a program in England that shows spending 1 hour a week with someone, befriending them, who has serious psychosis, makes a really substantial difference in their lives. And the fourth one is that we have to believe that we can understand what's going on. This isn't incomprehensible. This isn't, it's just, they're crazy and they don't understand it, we need to force them. No, we can be in their worlds. We can share their worlds. We can be a part of them. We can be connected. We can lead to recovery. This is an intensely human enterprise. And if the enterprise is person, relationship-based healing and growth, then the whole system has to emphasize that, not some other values about revenue generation or we're not making widgets here. We're making relationships that help people grow and change. And it's not just the people in the system. That's true of the neighbors and the business worker and their employer, the professor at the school, the policeman, everybody. We can have them be part of our worlds. We can build a bridge back from where they're suffering by themselves to be reconnected with us, welcoming them back.
And if I could just add to that, Carrie, because as that last thing that Mark said, it's not just about what are the professionals doing. It's like one of the reasons why I've been so enamored with the Trieste project is because of the way that you had the entire community, particularly the business community and the faith community, be a part of the project. I think that is, as Mark was just saying, absolutely crucial in making this work. We can't continue to believe that, it's just a professional problem. It's a problem for all of us. But I think that of all of the communities that I've seen, you've done the best job at sort of bringing in those people and helping them to see their role and their part in improving the system.
And you don't, that's why I take issue with David's thing about saints. You don't need to be a saint to be hang out with people with mental illnesses. You need to be curious. You need to be unfrightened. You need to be understanding, and you need to be connected, and you need to be hopeful. And lots of people can be those things.
I think in the 4 items you laid out and Dave's amplifying, everybody heard something that they could do a little bit different to that create that social human connection that can be so therapeutic and so transformative. I am so inspired by what I heard today, and I'm so excited to share this story far and wide, and hopefully that it will stimulate people to think about what they can do, whether they be elected officials, whether they be community members, family members, consumers, to keep pressing forward for the change that we know we cannot be satisfied with the status quo. So, gentlemen, thank you, and I hope you enjoy the rest of your Saturday afternoon.
You're welcome,
Thank
Carrie.
you. It's our pleasure.
Thank you. It strikes me as I listen to this case study, we know what has to be done, but do we have the political will to change things? Dave Pilon was instrumental in drafting the proposal for the Trieste innovation for consideration by California's Mental Health Services Act Oversight Committee in 2019. It was primarily a payment reform proposal, buttressed by a significant commitment to building out the community connections, vocational opportunities, and support to people in the pilot area. We are in a tussle between 2 poles. To treat mental illness in our society, do we cling to an outdated medical model, or do we shift to an approach which integrates services in the community with accountability to the person being served? In the episode notes, I will provide a link to the studies that are referenced in the discussion today, and also to a book recently published by Mark Ragins, which speaks to this polarization so eloquently. It is called Journeys Beyond the Frontier, a rebellious guide to psychosis and other extraordinary experiences. Next week, we will hear from Dr. Roberto Mezzina, the recently retired director of the world-renowned community mental health system in Trieste, Italy. He was in town at the behest of the LA Sheriff's Foundation to do some training with their homeless outreach and mental evaluation team. What you hear might shatter perceptions you hold of the LA Sheriff's Department. This podcast is 100% supported by its listeners. Thank you. My gratitude is also extended to Verdugo Sound, who provides the recording and editing support for this podcast.